From treating suicidal depression as loneliness, to dismissing manic episodes as personality changes, to watching doctors mistake psychosis for dementia, these are the mental health symptoms getting misdiagnosed in patients over 50. And they're happening so often, there's a good chance your doctor has made at least one of these mistakes in the past month. Because right now, over 2 million Americans over 50 are walking around with the wrong mental health diagnosis. Not a misdiagnosis where nothing was found, the wrong diagnosis. The kind where you spend 6 months getting cardiac tests for what's actually a panic disorder, or take dementia medication for what's really just severe depression, or get shuffled between specialists while late-onset bipolar destroys your life because everyone assumed personality was fixed at your age. And the consequences? Thousands dead from preventable suicides. Tens of thousands on medications that make their actual condition worse. Hundreds of thousands suffering for months or years before someone finally connects the dots. But first, is depression misdiagnosed as dementia? Which isn't some rare medical mystery, it's one of the most common diagnostic failures in medicine today. Depression isn't exactly what most people worry about when their 6-7-year-old parent starts forgetting appointments. In fact, if you asked 100 doctors what's causing memory problems in older adults, most would jump straight to Alzheimer's. But they're wrong about 15% of the time, and that mistake ruins lives. Because in 2019 alone, over 280,000 Americans over 50 were diagnosed with cognitive decline, except roughly 42,000 didn't have dementia at all. They had severe depression presenting as cognitive impairment, a condition so common it has its own medical term: pseudo-dementia. Here's how it happens. Patient comes in with memory loss, confusion, difficulty concentrating. Classic dementia symptoms. Doctor runs a cognitive test, maybe orders a brain scan, sees age-related changes, prescribes dementia medication. Case closed. What they missed was the depression. Because unlike younger people who show up crying, older adults with depression often don't present emotionally. They show up with what looks like cognitive decline, withdraw socially, stop caring about hobbies, struggle to remember because depression wrecked their ability to concentrate. Once you're labeled with dementia, that diagnosis follows you everywhere. Every doctor assumes the problems are degenerative and irreversible. So instead of treating depression with therapy and antidepressants that work, you get dementia drugs that do nothing. Some make depression worse. The numbers are staggering. Up to 7 million Americans over 65 have depression, but only 35% receive treatment. And of those who seek help, a significant chunk get misdiagnosed with cognitive disorders. Take a typical case. A 72-year-old woman forgets her keys, misses appointments, seems confused. Family brings her in worried about Alzheimer's. Doctor does a mini mental state exam. She scores 23 out of 30, below the dementia threshold. Brain scan shows age-related atrophy. Diagnosis: early dementia. Nobody asked if she was sleeping, if she'd lost interest in her garden, if she felt hopeless, if her husband died 6 months ago and she'd been falling apart. Because grief-induced depression doesn't look like sadness in older adults. It looks like someone whose brain is shutting down. And when doctors see that, they think neurodegenerative disease, not major depressive episode. So she gets Aricept, a drug for dementia, that doesn't help depression. Her symptoms continue. Family watches helplessly, convinced they're losing her to an incurable disease. Months later, someone finally recognizes the depression. By then, the patient spent months in unnecessary despair. Family's traumatized, everyone's convinced the decline is permanent. But here's the kicker. When depression in older adults is treated correctly, the dementia symptoms often disappear completely. Memory comes back. The person you thought you were losing returns. Dementia is progressive and irreversible. Depression responds to treatment, sometimes dramatically, but you have to diagnose it first. And doctors keep missing it because there's this assumption that sadness is normal for older people. But clinical depression isn't a little down. It's a serious condition that can present as cognitive impairment. The tragedy? This is preventable. A proper psychiatric evaluation would catch it. Even just asking, "Do you feel sad or hopeless most days?" would help. That question often never gets asked. And thousands continue living with untreated depression, diagnosed with a disease they don't have, taking medications that won't help. But at least depression can eventually be caught. Not like this next condition, which doctors mistake for something completely different and waste months and thousands chasing the wrong diagnosis. A 58-year-old man wakes up at 3 a.m. with crushing chest pain, heart racing, drenched in sweat, convinced he's dying. ER. They hook him up, run tests. Everything's normal. Probably stress, they say. Follow up with your doctor. So he does. The doctor sees ER visit for chest pain. Orders more tests. Stress test. Echocardiogram. Maybe cardiac catheterization. Cost $5,000 to $15,000. All normal. But the symptoms keep happening. Every few weeks, same thing. Chest pain, rapid heartbeat, shortness of breath, dizziness, impending doom. More tests. Check thyroid. Holter monitor. Still, nothing. 6 months later, after thousands in cardiac workups, someone finally asks, "Do you ever feel anxious?" That's when it unravels. What he's experiencing isn't heart disease, it's panic disorder, one of the most commonly misdiagnosed conditions in patients over 50. Panic attacks feel exactly like heart attacks: chest pain, rapid heartbeat, sweating, shortness of breath, numbness, nausea. So similar that cardiologists can't distinguish without tests. When a 58-year-old shows up with chest pain, everyone thinks cardiac first. The problem is, doctors get stuck there. They keep testing for heart disease, even after multiple normal results, because just anxiety doesn't seem serious enough. Plus, there's this belief that anxiety is something young people get. Wrong. About 15% of adults over 55 have an anxiety disorder, but less than half receive treatment. Many get misdiagnosed because symptoms present physically, not emotionally. Unlike younger people who say, "I feel anxious," older adults often don't report feeling anxious, they report physical symptoms, and doctors start looking for physical causes. So they spend months ruling out cardiac and pulmonary conditions, while the patient continues having panic attacks, each one reinforcing their belief they have an undiagnosed medical condition, which makes anxiety worse, which triggers more attacks. It's a nightmare cycle. And expensive. The average panic disorder patient visits the ER about 7 times before correct diagnosis. Each visit costs $500 to $3,000. Total $20,000 to $40,000 chasing a diagnosis that could have been made in 2 visits with a psychiatrist. But here's where it gets worse. Once you're a frequent ER visitor with medically unexplained symptoms, doctors treat you differently. They assume you're a hypochondriac. Quality of care drops. The panic attacks continue for years because nobody screened for anxiety. They just kept checking your heart. As you might have guessed, this doesn't work. Panic disorder isn't caused by stress you can reduce. It's a neurochemical condition. It requires treatment, CBT, and sometimes SSRIs, not vague advice about relaxation. When treated correctly, success rates are high. About 70–80% see significant improvement. The heart attacks stop. But that only happens if someone makes the correct diagnosis. And for thousands, that diagnosis is missed for months while they undergo unnecessary cardiac testing. The irony? Treatment costs a fraction of cardiac workups, couple hundred for evaluation, maybe $30 monthly for medication, 10 CBT sessions, total under $2,000. But nobody gets there because the first doctor saw chest pain and went straight to cardiology. If you thought wasting thousands on wrong tests was frustrating, this next condition doesn't just waste money, it actively accelerates the real problem. A 62-year-old woman starts losing weight. Not intentionally, she's just not hungry, forgets to shower. Her daughter notices mom's house is messier, dishes piling up. At dinner, mom seems distant, forgetful, repeating herself. The daughter brings her to the doctor. Cognitive assessment, blood work. Everything's normal. Diagnosis? Probably early cognitive decline. Come back in 6 months. Months later, worse. Mom loses another 15 pounds, sleeps until noon, stopped answering the phone. The daughter finds expired food, unopened mail everywhere. Back to the doctor. He prescribes an antidepressant, except he never asked about alcohol, never asked about pills, never looked in the medicine cabinet where there are 3 bottles of Xanax from 3 different doctors, plus Ambien every night for a year, plus Tramadol from a knee replacement. What everyone thought was dementia or depression was actually prescription drug dependence, and the antidepressant he just prescribed interacts badly with benzodiazepines, making everything worse. Substance abuse in adults over 50 is one of the most underdiagnosed conditions in medicine. We're not talking stereotypical addiction. We're talking people who got prescriptions for legitimate pain or anxiety, took them as directed, and slowly became dependent without anyone noticing. About 1 million adults over 65 misuse prescription medications, jumping to over 5 million, including alcohol. But doctors screen for substance abuse in older adults at significantly lower rates. Why? Because there's this assumption that nice older people don't have drug problems. Wrong. Older adults are uniquely vulnerable because they're more likely to have chronic pain, insomnia, anxiety conditions treated with potentially addictive medications. Plus, they metabolize drugs more slowly. A Xanax dose fine for a 30-year-old causes significant cognitive impairment in a 65-year-old. But when an older patient shows up with dementia, not substance abuse, because mom's not drinking vodka at 9 a.m., she's taking medications doctors prescribed. Here's how it happens. Doctor prescribes Xanax for anxiety after a spouse dies. Works great. Few months later, anxiety returns, she takes more. Another doctor prescribes Ambien for insomnia. Knee replacement leads to tramadol. Now she's on 3 central nervous system depressants, and nobody's coordinating care. The effects snowball. Cognitive impairment worsens. Falls. Appetite decreases. Social withdrawal. Sleep disrupted, leading to more sleep medication. And everyone thinks this is normal aging. Meanwhile, the substances are causing the exact symptoms everyone's trying to treat. Benzodiazepines cause memory problems that look like dementia. Opioids suppress appetite. Sleep medications disrupt normal sleep, making insomnia worse, creating a cycle where the patient needs more medication. It's called tolerance. Happens gradually. The patient doesn't realize they've gone from 1 Ambien to 2 Ambien plus Xanax plus wine because nothing works. And because older adults often live alone, nobody notices the escalation. By the time someone does notice, the dependence is entrenched. Stopping suddenly can cause dangerous withdrawal. Benzodiazepine withdrawal can be life-threatening. Substance abuse in older adults is highly treatable when correctly diagnosed. Supervised tapering, CBT, addressing underlying issues can completely resolve the problem. Patients who looked like they were developing dementia suddenly have cognitive function return. But that only happens if someone asks the right questions. What medications are you taking? All of them. How many pills daily? Do you ever take more than prescribed? Those questions don't get asked, so the misdiagnosis continues. And the patient spirals while everyone wonders why the decline is so fast. But none of that compares to this next disaster, where doctors mistake a life-threatening condition for simple stress, and patients die within weeks. A 69-year-old man stops talking. Not gradually, suddenly. Over a week, he goes from normal conversation to one-word responses to complete silence. Won't get out of bed, won't eat, just lies there staring at the ceiling. His wife brings him to the doctor. Physical exam, vitals check. The wife explains her husband's brother died 3 months ago. The doctor nods. Grief, he says. Give it time. Get him out more. 2 weeks later, the man still hasn't spoken. Lost 12 pounds because he refuses to eat. His wife is forcing water to prevent dehydration. She calls the doctor. He prescribes an antidepressant, says it'll take 4 to 6 weeks to kick in. 3 weeks after that, the man is found unresponsive, severely dehydrated, and malnourished. Rushed to the ICU, psychiatrist finally consulted. Diagnosis? Catatonic depression. A severe, life-threatening form of major depressive disorder where the patient becomes frozen, unable to move, speak, eat, or care for themselves. And here's the insane part. The first doctor saw textbook catatonic depression, sudden mutism, refusal to eat, complete withdrawal, and diagnosed it as normal grief. What the heck, man? Catatonic depression is a psychiatric emergency, not something you wait out. It requires immediate intervention, hospitalization, aggressive treatment with benzodiazepines or ECT. Close monitoring because patients can die from dehydration, malnutrition, or immobility complications. But doctors miss it constantly in older adults because there's this assumption that extreme sadness is understandable at that age. Spouse dies, health declines, you retire, of course you're depressed. So when an older patient shows profound symptoms, doctors think, makes sense given circumstances, not medical emergency. The problem is, there's a massive difference between normal grief and catatonic depression. Normal grief is sadness, crying. Catatonic depression is complete shutdown. The brain stops sending signals to move, speak, or respond. Studies show older adults have the highest suicide rate of any age group. Men over 65 have a suicide rate of about 30 per 100,000, compared to the national average of 14. And about 75% of older adults who die by suicide saw their primary care physician within a month of their death. That means they showed severe depression symptoms, and the doctor either didn't recognize it or didn't think it was serious enough for aggressive intervention. Why? Ageism in medical care. Depression is expected in older adults, so it doesn't trigger alarm bells. A young person who stops speaking would be in the psychiatric unit within hours. An older person gets told it's grief, sent home with, stay active. And it's not just catatonic depression. Severe depression with suicidal ideation gets dismissed constantly. They mention feeling hopeless, not wanting to wake up, thinking about death. Doctor asks, do you have a plan? Patient says no. Doctor checks a box, documents, denies suicidal intent, moves on. No safety planning. No immediate psychiatric referral. Just a prescription and an appointment in 6 weeks. 6 weeks. For someone expressing passive suicidal ideation, that's insane. Because passive suicidal ideation, I wish I wouldn't wake up, can escalate to active planning incredibly fast in older adults who use more lethal methods. A 70-year-old isn't impulsively overdosing on Tylenol. They're using a firearm, and they're going to die. But doctors don't treat it with urgency because the patient has legitimate reasons to be depressed. So depression gets normalized as part of aging rather than recognized as a treatable condition. And when someone dies, everyone acts shocked. We had no idea it was that serious. No. It was major depressive disorder with suicidal ideation, and it was missed because the doctor assumed sadness at 70 is normal. The treatment for severe depression in older adults is remarkably effective. Antidepressants combined with therapy have a 60-70% response rate. ECT has response rates over 80%. But that requires someone to first recognize the patient has severe depression requiring immediate treatment, not normal sadness requiring time. And right now, that recognition is failing thousands every year. Sheesh. I mean, you'd think after all these disasters, doctors would be more careful. Think again. Because this next condition gets misdiagnosed so often, patients end up labeled as difficult, shuffled between doctors who blame personality problems instead of recognizing a treatable disorder. A 64-year-old veteran starts acting paranoid, convinced neighbors are watching, gets into arguments over perceived disrespect. His daughter tries to talk about getting help. He accuses her of conspiracy. When she convinces him to see a doctor, he's combative, storms out halfway through. The doctor documents patient, uncooperative, and paranoid personality features. No psychiatric referral, no trauma screening. Just a note that the patient was difficult. Daughter tries another doctor, same result. The veteran walks in defensive. The doctor reads the difficult notes, treats him accordingly. More documentation. Patient. Hostile. After 3 or 4 doctors, the veteran's been labeled. Every chart note includes difficult patient, paranoid thinking, anger issues. Once that label's in the system, it follows him everywhere. Nobody digs deeper. Nobody asks about military service. They just see difficult old man and try to get him out fast. What nobody diagnosed was severe PTSD. He'd served in Vietnam 45 years earlier, came home, buried it, functioned for decades. But retirement triggered something. Nightmares came back. Hypervigilance intensified. The paranoia about neighbors wasn't delusional. It was PTSD-driven hypervigilance, where every person feels like a threat. The anger wasn't a personality flaw, it was a trauma response. But because he was labeled difficult, nobody treated his condition. He descended into isolation, worsening symptoms, eventually stopped trying to get help. And this pattern is incredibly common. About 11% of veterans over 60 have PTSD. But diagnosis rates are lower because older veterans don't recognize symptoms as PTSD. They think it's just who they are now. And when they seek help, professionals miss it because they're looking at an angry old man, not a traumatized veteran. Same thing happens with late-onset schizophrenia. Patient exhibits paranoia, hears voices. Doctor sees difficult patient with paranoid thoughts, labels it personality disorder without investigating what's causing the psychosis. What should happen is thorough psychiatric evaluation. Is this new-onset schizophrenia, PTSD, medication-induced psychosis, brain tumor, treatable medical cause? None of those questions get asked because the patient is uncooperative, and uncooperative patients are problems, not puzzles to solve. So instead of a workup, the patient gets labeled. That label is permanently attached. Every future healthcare interaction is colored by it. ER visits get dismissed because known, difficult patient. It's medical gaslighting at scale. The system says, you're difficult, you're non-compliant, you're the problem. And the patient, already struggling with mental health symptoms that make them distrustful, has that mistrust confirmed at every encounter. The consequences are catastrophic. Patients stop seeking care. PTSD leads to substance abuse, homelessness, suicide. Psychotic disorders spiral into full breaks because nobody prescribed antipsychotics. And it's all preventable. Trauma-informed care exists. It's a framework where professionals understand difficult behavior often stems from trauma, fear, or mental health conditions rather than personality flaws. But trauma-informed care requires training, patience, time. It's easier to write difficult patient and move on. There are roughly 5.6 million veterans over 65. If 11% have PTSD, that's over 600,000 older veterans. How many are labeled difficult patients instead of getting trauma treatment? The tragedy is most of these conditions are treatable. PTSD responds to trauma therapy. Schizophrenia can be managed with antipsychotics, but treatment requires diagnosis. And diagnosis requires someone to look past the difficult patient label. And if you think being labeled difficult is bad, wait until you hear about this next condition, where doctors not only misdiagnose, but actively make it worse by prescribing medication that triggers the exact opposite of what they're trying to treat. A 5-6-year-old woman goes to her doctor complaining about depression. Feeling down for months, can't sleep, lost interest in everything. Doctor confirms depression, prescribes Zoloft. She starts taking it. 3 weeks later, she's not sleeping at all, talking a mile a minute, spent $8,000 on a Vegas trip, convinced she should quit her job to start 3 businesses. Her husband is terrified. This isn't depression, this is mania. Back to the doctor. He stops the Zoloft, prescribes a mood stabilizer, refers to a psychiatrist. The psychiatrist asks the right question. Have you ever had periods where you felt extremely energetic, needed less sleep, or felt on top of the world? Yes. Multiple times, over 20 years. She just thought those were times when she was feeling good. Turns out, she had bipolar disorder the entire time. But because she only sought help during depressive episodes, and doctors didn't screen for mania history, she got diagnosed with regular depression. And when you give someone with bipolar an antidepressant without a mood stabilizer, you can trigger a full manic episode. This is one of the most dangerous misdiagnoses in psychiatry, and it happens constantly in patients over 50. Because bipolar doesn't always start in your 20s. Late-onset bipolar exists, but even more commonly, people have had bipolar for years without knowing, seeking treatment only during depressive episodes. Studies estimate 20–40% of people diagnosed with major depression actually have bipolar, and the average time from first seeking treatment to correct diagnosis is 8 to 10 years. That's a decade of wrong treatment. Here's why it matters. Antidepressants alone can destabilize people with bipolar. They can trigger mania, rapid cycling, or mixed episodes where you're depressed and manic simultaneously, which significantly increases suicide risk. And the consequences are catastrophic. During manic episodes, people quit jobs, drain savings, engage in risky behavior. The average person with untreated bipolar accumulates about $80,000 in debt from spending sprees. Relationships destroyed. Careers imploded. Then comes the crash. The depression following mania is often severe, sometimes with psychotic features, carrying extremely high suicide risk. People with bipolar have a suicide rate 20 to 30 times higher than the general population. So why do doctors keep missing it? First, patients almost never come in during manic episodes because they feel great. You don't seek help when you're on top of the world. You seek help when you crash. So doctors only see the depressive side. Second, doctors often don't take detailed psychiatric histories. A proper bipolar screening requires asking about past elevated mood, decreased sleep need, racing thoughts, impulsive behavior. But in a 15-minute appointment, most just confirm depression and prescribe an antidepressant. Third, hypomania can be subtle. Sometimes it's just a few days, feeling really productive, sleeping 5 hours instead of 8, having more energy. People think, I'm just having a good week. They don't report it because they don't realize it's a symptom. And fourth, age bias. Doctors assume bipolar starts young, so when a 60-year-old presents with depression, they don't consider bipolar. The treatment difference is massive. Major depression gets SSRIs. Bipolar depression requires mood stabilizers, like lithium, sometimes antipsychotics, and only carefully monitored antidepressants if necessary. Put someone on wrong treatment, you're actively causing harm. When bipolar is correctly diagnosed and treated, outcomes improve dramatically. Mood stabilizers can reduce episodes by 70–80%. People get their lives back. But that only happens if someone recognizes the pattern before prescribing antidepressants. The checklist is simple. Before diagnosing depression and prescribing SSRIs, ask, have you ever had periods where you felt extremely energetic, needed much less sleep, were much more talkative, had racing thoughts, or engaged in risky behavior? If yes, do a full bipolar assessment first. But that question doesn't get asked. So thousands continue on antidepressant monotherapy for what's actually bipolar, experiencing cycles of worsening depression and occasional medication-induced mania, never understanding why treatment doesn't work. And speaking of treatments that cause harm, this next condition is even worse, where delayed diagnosis causes permanent, irreversible brain damage. A 61-year-old accountant starts acting strange. Not dementia, strange personality strange. Always been reserved, but now he's making inappropriate sexual comments to coworkers. Spending money impulsively. Laughing at funerals. His wife notices he's obsessed with routines. Eating the same meal every day in exact order. Getting irrationally angry if interrupted. She convinces him to see a doctor. Cognitive screening. Memory seems mostly fine, though some word-finding difficulty. Diagnosis. Early depression with personality changes. Prescribes an SSRI, suggests therapy. Over the next year, worse, loses his job after inappropriate comments, gained 30 pounds from compulsive eating. Language deteriorating, can't find common words, sometimes uses completely wrong words. Inappropriate behavior escalates. Back to the doctor, who now thinks early onset dementia. Orders an MRI. The scan shows frontal and temporal lobe atrophy. That's when the neurologist finally makes the correct diagnosis. Frontotemporal dementia, FTD. But by now, it's been 2 years. The personality changes are permanent. The language problems are progressive and irreversible. The brain damage is already extensive. What should have happened? Neurological workup at the first appointment. Because sudden personality change in a middle-aged adult isn't depression, it's a red flag for neurological disease. Frontotemporal dementia typically begins between ages 45 and 65. And the hallmark symptom isn't memory loss, it's personality change. Loss of empathy. Socially inappropriate behavior. Compulsive behaviors. Loss of inhibition. Changes in eating. Apathy. These are FTD symptoms, and they look nothing like Alzheimer's. But because doctors assume all dementia looks like Alzheimer's memory problems in elderly patients, they miss FTD when it shows up as personality problems. FTD affects about 60,000 Americans, but average time from symptom onset to diagnosis is 3.6 years. That's 3.5 years of wrong treatment, worsening symptoms, job loss, relationship destruction, and irreversible brain damage. And early diagnosis matters enormously, not because there's a cure, but because interventions can help manage symptoms and slow decline. Speech therapy, behavioral interventions, and families need time to prepare, make legal arrangements, understand that their loved one's behavior isn't intentional, it's neurological. But families don't get that time when diagnosis is delayed. They spend years thinking their husband or wife is just being selfish or cruel. Relationships implode because nobody understands the behavior is caused by brain disease. And FTD isn't the only condition with this pattern. Autoimmune encephalitis, where the immune system attacks the brain, can present almost identically. Sudden personality change, bizarre behavior, psychiatric symptoms. But if caught early, it's potentially reversible with immunotherapy. Wait too long, brain damage becomes permanent. A woman in her 50s develops panic attacks, then paranoia, then full psychosis over weeks. Hospitalized in a psychiatric unit, treated for new-onset schizophrenia. Antipsychotics don't help. She develops seizures. Finally, 3 months in, someone orders antibody tests. Diagnosis: anti-NMDA receptor encephalitis. She gets immunotherapy, psychiatric symptoms resolve. But 3 months of inflammation caused permanent cognitive deficits. If someone tested in week 1 instead of month 3, she might have recovered completely. But nobody tested because she was presenting with psychiatric symptoms, and the assumption was psychiatric symptoms mean psychiatric disease. They're not. The brain is an organ. Diseases that affect the brain can cause psychiatric symptoms. Brain tumor can cause depression. Lupus can cause psychosis. B12 deficiency can cause paranoia. And FTD, or autoimmune encephalitis, can cause personality changes that look like psychiatric disorders. But the medical system has a psychiatric versus neurological divide that prevents integrated thinking. Patients with conditions that cross this boundary fall through cracks. The consequences are devastating for families. They watch a loved one transform into someone unrecognizable. They're told it's depression or bipolar. They try medications that don't help. The person gets worse. Some families give up because they can't handle the behavior. Then, years later, they get the neurological diagnosis and realize the person they abandoned wasn't choosing to act that way. Their brain was literally deteriorating. That's the permanent cost of delayed diagnosis. Not just lost time, but permanent brain damage, destroyed relationships, and families living with guilt because they didn't understand until too late. No list of dangerous misdiagnoses would be complete without the one condition doctors miss more than any other in patients over 50. And it's happening right now. A 6-8-year-old man mentions to his doctor he's been feeling down. Doesn't see much point in things. Wife died 2 years ago. Kids live in other states. Retirement's lonely. Doctor asks, "Are you thinking about hurting yourself?" The man pauses. "Not really," he says. "I just sometimes think it would be easier if I didn't wake up." The doctor makes a note. Passive suicidal ideation, no plan. Prescribes an antidepressant. Schedules follow-up in 6 weeks. The man leaves. 3 weeks later, he's dead. Gunshot. Except he told his doctor he wished he wouldn't wake up. And the doctor documented it, checked a box, sent him home with a prescription and an appointment 6 weeks away. This is the most dangerous misdiagnosis. When a 6-8-year-old says he wishes he wouldn't wake up, that's not passive ideation you monitor over 6 weeks. That's active suicide risk requiring immediate intervention. Adults over 65 have the highest suicide rate of any age group. For men over 85, the rate is nearly 50 per 100,000, more than 3 times the national average. And about 75% of older adults who die by suicide saw their primary care physician within 1 month of their death. That means they were showing severe depression symptoms, sometimes explicitly mentioning thoughts of death, and the doctor's response was inadequate. A prescription. A follow-up in weeks. Not immediate psychiatric evaluation. Not hospitalization. Not same-day safety planning. Why? Because of this pervasive, deadly assumption that sadness is understandable in older adults. Spouse dies, health declines. You lose independence, of course you're sad. So when an older patient expresses hopelessness or thoughts of death, doctors think, given circumstances, that's reasonable, rather than, this is a psychiatric emergency. But there's a massive difference between grief and suicidal depression. Grief is painful, but doesn't involve persistent thoughts that life isn't worth living. Suicidal depression is a medical crisis where the brain's capacity to see alternatives is chemically disrupted, and it requires immediate intervention. The other reason doctors miss it? The screening questions are inadequate. Do you have a plan? Seems good, until you realize many older adults with genuine suicidal intent say no because they know yes leads to involuntary hospitalization. So the doctor documents, denies suicidal plan, and moves on. No safety assessment. No inquiry about access to firearms, used in over 70% of suicide deaths in older men. No discussion with family. Just a prescription and call if it gets worse. But it gets worse fast. Unlike younger people who may have multiple attempts, older adults tend to use highly lethal methods on first attempt. When a 70-year-old decides to end their life, they're not impulsively overdosing. They're using firearms or hanging. And they're doing it when nobody's home. The window for intervention is narrow. A person can go from passive ideation to active planning to completed suicide in days or hours, and doctors keep missing this urgency. They treat suicidal ideation in a 70-year-old the same way they'd treat it in a 5-year-old outpatient management. Medication that takes weeks to work, therapy appointments scheduled weeks out. What should happen? Any expression of suicidal thoughts in an older adult should trigger immediate psychiatric evaluation, same-day crisis intervention, assessment of lethal means, safety planning involving family, for severe cases, hospitalization, but that's not happening. Emergency departments routinely discharge older adults expressing suicidal ideation if they deny imminent intent. Mental health systems have wait lists stretching months. So people fall through cracks. They express hopelessness, get sent home with inadequate support, and die before their follow-up. The pattern across all these misdiagnoses is the same: ageism, stigma, system failures. Medical professionals assume sadness and decline are normal parts of aging. Mental health symptoms are dismissed as character flaws. And even when diagnoses are correct, getting appropriate, timely care is nearly impossible. This is happening right now. Today, in doctors' offices across the country, older adults are being told their depression is understandable. Their suicidal thoughts are being documented and ignored. Their treatable conditions are going untreated while they suffer or die. But there you have it, the mental health symptoms doctors keep misdiagnosing in patients over 50. Depression mistaken for dementia. Panic attacks as heart disease. Substance dependence blamed on aging. Catatonic depression dismissed as grief. PTSD labeled as difficult personality. Bipolar triggered by wrong medications. Frontotemporal dementia treated as depression while the brain deteriorates. And suicidal ideation documented then ignored until it's too late. The system is failing at every level. If you thought these diagnostic failures were disturbing, wait until you see what happens when doctors do diagnose correctly, but insurance companies deny treatment. Click here to watch that next, because this crisis only gets worse from here.